All right, so welcome to psychopharmacology. Today we're going to talk about depression or mood disorder. So remember, there's a spectrum, right? So you have one side, which is MDD, major depressive disorder, and you have the other side, which is what? Mania, right? So you have someone who's only depressed, unipolar depression, you have bipolar depression, which has two parts to it, right? You have bipolar 2, which someone has mania, and you have, I'm sorry, bipolar 1, which someone has mania, and you have bipolar 2, which someone has hypomania. Even though this isn't a diagnostic class, it's good to touch on it a little bit, but what distinguishes bipolar 2 from bipolar 1? Anyone know? What's the difference between bipolar 2 and bipolar 1?
Isn't bipolar 1 usually diagnosed by the mania first, or generally is, and then bipolar 2, it's more often depression, and then, like you said, hypomania, which doesn't actually quite reach the level of full mania.
That's correct. So the interesting thing about bipolar 1 is someone can have the diagnosis of bipolar 1 and not have any depressions, all right? You just have to have one manic episode. So that could be a trick question. Someone could come into the ER and they're talking fast, they haven't slept for a couple of days, they're hearing voices, then you diagnose them with mania, that already fits criteria for bipolar 1. They might have depression down the road or they might have had a depression, but they don't remember it, but that still meets criteria for bipolar 1, all right? Even though this is a diagnostic class, just to have that and understand that, all right? Okay, backtracking. Now we're going to talk about MDD because that's pretty straightforward. So MDD stands for major depressive disorder or AKA unipolar depression, all right? So if you look at most guidelines, the main treatment really is what? First, what class of medications do we use as first line usually for unipolar depression? What is it?
That's all right.
Very good, right? Serotonin reuptake inhibitors. Give me some examples of serotonin reuptake inhibitors.
Fluoxetine,
Mhm.
paroxetine, sertraline.
Okay. Give me two more.
Citalopram,
Very good.
escitalopram.
Very good. Citalopram, escitalopram. All right. So citalopram and escitalopram, they're pretty much almost the same medications, right? Because they're enantiomers of each other. If you guys remember from organic chemistry, you have the R and S enantiomer, right? The only difference is that citalopram can go all the way up to 40 milligrams, and escitalopram only goes up to 20. All right. That's important to know because 40 milligrams of citalopram, Celexa, you should do EKG on the patient. Why? What can citalopram do? At about 40 milligrams or at 40 milligrams, could cause something. Abnormal what? EKG, what is it called?
QTC intervals
Yes, what about it? Is it going to be shortened or is it going to be long? Long.
increased.
Very good, right? So it's going to call QTC prolongation, right? Which can lead to torsades de pointes, which can lead to a lethal arrhythmia, all right? So just be aware there's a family history of any arrhythmias. Maybe that might not be the best first line option for the patient, all right? Fluoxetine. Fluoxetine is a good medication because, it's FDA approved for kids as young as 7, I believe. So when I was doing child psychiatry, I was using fluoxetine a lot. I tend not to use fluoxetine a lot for adults anymore. Why? What does fluoxetine have that might not contraindicate it, but make me hesitant to use it with adults? What can it do? Is a potent what?
Anticholinergic?
Not anticholinergic.
No.
It's about enzymes. It does something with the
The
CY.
2D6 inhibitor.
Very good. So what does that mean?
Any drug that's a substrate of 2D6 will be increased.
Very good. Excellent. It's a 2D6 inhibitor. All right. Now, the downside to fluoxetine also, which also could be good about it, is that it has a very long half-life. So the active metabolite called norfluoxetine has a half-life of about 1 week. So if a half-life is 1 week, how long would it take for the medication to wash out if the half-life is 1 week? What do you guys think?
5 weeks.
5 weeks. Very good. Right. So this happens a lot. And this is a pharmacokinetic issue that happens with patients that come to me and they say, hey, my last prescriber put me on Abilify. No, I'm sorry. My last prescriber put me on a medication for depression, but I don't remember the name of it. But I just know that I didn't like the way it made me feel. Uh, it made me feel restless when they put me in this new medication. And now I just want to stop medications, but I want to talk to you first. And I say, what was the medication they put you on that made you feel like crap? Abilify, right? So They don't know what the name of the first med was, but they're having side effects from the Abilify. So I have to put two and two together and realize that maybe that medication they put that's still giving them a pharmacokinetic interaction is fluoxetine. Understand? So if a patient comes to you and they were prescribed a medication for depression by their primary care doctor, try to figure out if it was fluoxetine. Because even if their last dose was 2 weeks ago, or the last dose was 3 weeks ago, or even 4 weeks ago, any other medication that's a 2D6 substrate is going to be increased. So they're going to have side effects. So you have to make sure you do dose adjustments. All right. So any 2D6 medication like a beta blocker, propranolol, you want to give propranolol for anxiety, you have to give them half because the fluoxetine that's still in the system is going to take 5 weeks to wash out, and it's going to increase the dose of 2D6. Does that make sense? All right. So SSRIs, usually are first line. They're usually, benign compared to other medications. Fluoxetine, longest half-life. What's the opposite of fluoxetine that has a short half-life? That's also an inhibitor. What's the name of it? Starts with a P.
Oxetine?
Paxil or
Oh,
paroxetine, right? Sharon, so you mentioned anticholinergic. That's what you're talking about,
Mm,
paroxetine,
okay.
right? That's why we tend not to use it with older clients because it's anticholinergic, antihistamine, and it can make them confused and also can make them fall. So be aware of fall risks with Paxil and confusion, all right? So sometimes I'll see older patients come to me. They were prescribed by some old school psychiatrists or NPs because back in the day they used to use Paxil a lot more because they believed that it was very good for anxiety. Of course, if you're sleeping all the time, you're tired all the time. It's hard to be anxious and it's hard to be anxious when you're sleepy, right? So they're not anxious, but they want to sleep all the time or they're lethargic because you're giving them Paxil. So just be aware of that. All right. Also know that Paxil has the highest rate of sexual dysfunction with ours. Since it is Valentine's Day, we'll talk about that. That is a common side effect of SSRIs is sexual dysfunction. So make sure that you do a good assessment with your patients. So assess functioning before and then ask them again when you increase the medication. All right. Um, Another option for major depressive disorder would be what? So let's say increasing serotonin is not effective. What's another class of medications that are reuptake inhibitors that we use?
SNRIs,
SNRIs, very good. And what is an example of an SNRI?
Venlafaxine,
Very good. Effexor. Okay, what's the other one?
duloxetine?
Okay, very good. Cymbalta. Give me another one.
Desvenlafaxine.
That's venlafaxine, Pristiq. All right. What's the difference between Pristiq and Effexor? What's the difference between desvenlafaxine and venlafaxine? Is there a difference?
Is desvenlafaxine the metabolite of venlafaxine?
Yes, it is the active metabolite of desvenlafaxine. So technically, if you take Effexor and you have a normal 2D6 system that metabolizes it, you're getting Effexor, Pristiq, I'm sorry, from Effexor, right? It metabolizes to Effexor. If patients are, poor metabolizers, right, and they take Effexor, there's not going to be effect because it's not going to metabolize the Effexor to desvenlafaxine, right, Pristiq, so you're not going to get the effect of the medication. So sometimes if I do genetic testing with the patients and I see that they're not able to metabolize it to the active metabolite, I'll try to get a prior authorization and switch them to Pristiq, desvenlafaxine. Does that make sense? Because it has to be metabolized for it to be effective. So therefore, if they don't have the enzyme to metabolize it, I have to give them the active metabolite that's already converted. All right? Does that make sense?
But why not just give them a Prestige in the first place?
Because it's expensive and insurance won't pay for that.
Got it.
Yeah, it's more expensive. In an ideal situation, yes, but sometimes insurance will only pay for the older medications. Yeah. So there's a lot of times in which you have a dilemma, right? You know which meds you want to prescribe your patients, but there's an issue with payers. They have shitty insurance, they have a high deductible, they have a high copay, and they can't afford it. So then you have to work with the patients and, figure it out. Maybe coupons, maybe samples from drug reps, try to get them the meds as much as you can, but if you can and cost is an issue, then of course you would have to prescribe them obviously the cheaper medication. All right. So those are times in which the cheaper meds might be, used more than the more branded medications. All right. So you have SSRIs, serotonin reuptake inhibitors, SNRIs, serotonin norepinephrine reuptake inhibitors. So usually when you increase serotonin, it helps with anxiety, right? It can help with, feelings of uneasiness. It can help with low mood. It might help a little bit with hypersomnia sometimes. But what if someone's issues are low motivation, low energy, right? You can't get out of bed because they feel like they're very heavy. Maybe an SN, norepinephrine, remember, is your fight or flight response. By increasing norepinephrine, you're giving someone the drive to get out of bed, all right? If someone's symptoms were, I don't know, anhedonia, I don't feel pleasure, it's hard for me to have focus, cognition, what would be a good option for that, for their MDD? What's the other class of medication? Which one?
DNRI,
DNRI, which is what? What's an example of DNRI?
bupropion.
Very good. Wellbutrin. All right. Wellbutrin is also a good medication if a patient has comorbidities of smoking cessation, right? Because we do use Wellbutrin. It's called Chantix. So be aware that I'm sorry, Zyban, not Chantix. Zyban. So sometimes you'll see patients, they'll say their primary care doctor put me on medication to help me stop smoking, and it'll be Zyban, which is technically bupropion. And then you put them on bupropion and they're getting double dose of bupropion. Get it? Because even though they know it's Zyban, it's branded, they don't know that Zyban is actually Wellbutrin. That's also an antidepressant. So maybe with that patient, you wouldn't put them on Wellbutrin. You're giving them the same dose or maximizing that dose. All right, does that make sense? But remember, Zyban is Wellbutrin SR, sustained release. It's a different formulation. It's the same as SR, not XL, which I usually use, extended release. So SR usually is dosed twice a day. XL is dosed once a day. I know it sounds the same, sustained release, but extended release is the one that has the long half-life, right? Which goes in 150 milligram increments, 150, 300, 450, all right? And just know Wellbutrin also itself is a very potent inhibitor of 2D6. So same concept. If someone is on Wellbutrin and you put them on a 2D6 substrate, like Evan said, it's an increase in dose. The only benefit about Wellbutrin over Prozac is that the half-life is shorter, so it's not going to stay in the system for that long. So technically, if someone's on Prozac for 5 weeks, they're technically a slow metabolizer of 2D6, right? Because it stays in the system for 5 weeks. So technically, you're making them a slow metabolizer because anyone gives them a 2D6 medication, it's going to go up already, technically. All right. Any questions with what I talked about so far? All right. So treatment for MDD. Now, even though this is in a diagnostic class, you guys should still know how to diagnose as MDD. All right. So it should be 2 weeks of SIGE CAPS. You guys know what SIGE CAPS is, right? SIGE-CAPS. S stands for sleep issues, right? Insomnia, initial insomnia, they can't fall asleep, or middle insomnia, they wake up in the middle of the night. I is interest, right? They have no interest in doing anything. They don't want to get out of bed. They don't want to go to work. G, they feel guilty. E, what's E? Low energy. C, poor concentration. A, appetite changes. P, psychomotor changes. They might be moving slower. S is suicidality. All right. So S, sleep. I, interest. G, feeling guilty. E, low energy. C, concentration issues. A, appetite changes. P, psychomotor changes. Usually it's slowing, retardation, right? S, sleep, suicidality. All right? Does that make sense? And if that happens for 2 weeks, then that would technically be an MDD episode, right? Major depressive episode. Does that make sense? All right? So 2 blue weeks, 1 fun week for mania. All right? For hypomania, it's 4 days. So mania, 7 days of less need of sleep, increased energy, risk-taking behaviors, right? Grandiosity, anger, agitation, maybe even some psychosis. All right, that happens for a week. That technically would be a manic episode. All right. If it happens for 4 days, it'll be a hypomanic. But once someone has psychosis, that automatically the threshold for me is mania. It can be 4 days. But once they have psychosis, that's automatically mania, all right? Automatically bipolar 1. Is that clear? Even though it's only 4 days. That's the distinction.
Do you find that
Mhm.
patients have a difficult time explaining or hypomania, or like you teasing out what hypomania is for them?
They
Because
do.
it is an odd concept for a person.
So what I'll usually say is, have you ever had periods where the opposite of depression, right? So whenever you diagnose someone MDD, the differential should always be bipolar depression, automatic. So I see you for the first time, you come to me for a depressive episode. I'm going to put provisional diagnosis, MDD versus bipolar depression, right? Because I always have to exclude, I have to make sure I rule out bipolar first before I go all in with the antidepressant, right? Because what happens if you give someone who has bipolar disorder a unipolar medication, right? Monoamine reuptake inhibitor. It can cause cycling, it can cause mixed features, it can cause agitation. And obviously, mixed features are dangerous because someone can be restless, not sleeping, and they're just going to kill themselves, right? Because they're still depressed, they're still suicidal. That's what you don't want. That might be the reason why there's a box warning for SSRIs because people are giving SSRIs like candy. They're not doing a good differential diagnosis and they're not ruling out bipolar, and the patient's actually getting worse with the medication. All right, that's why you should check in with them sooner. Usually, I'll say, Jerry, I know you're coming in for depression, but have you ever had the opposite of that? You know, days where you felt more productive, days where you didn't have to sleep as much, days where you felt really, really good, and you bought stuff you didn't need, and you regret it later on. You engage in behavior that you regret later on, right? Maybe you had promiscuous behaviors, you bought something that you didn't need, and you were like, I don't know why I bought that. Now I can't pay the rent. So risk-taking, impulsive behaviors. So the key is mania is increase goal-directed behavior without needing sleep. Increase goal-directed behavior without needing sleep, right? Because people can have not sleep, but they're tired. I haven't slept for 3 days. I wish I could crash. I'm not doing any goal-directed behavior. So that's the key thing there. Even though they're not sleeping, they're focused on doing something, researching something online, right? Quote unquote, trying to find the cure for something if they're psychotic and they're manic, all right? Or trying to write a book on something, even though they're not really writers. They're very grandiose and they're not sleeping. So what would be the treatment for bipolar disorder?
Lithium?
Yes, lithium is a good option. And tell me a little about lithium. So we're going to tease out lithium a little bit. What is it? What's the mechanism of action of lithium? Anyone?
Binds the sodium channels, which slows the action potential.
No, that's Depakote. So lithium isn't an anticonvulsant. That's the reason why it doesn't work with seizures because it doesn't affect those channels, right? If that was the case, you would give lithium for someone who has seizure disorder, but we don't. So there's a lot of theoretical reasons why they think lithium works. So it inhibits a lot of our messenger system that causes apoptosis, all right? So it inhibits something called GSK, glycogen synthase kinase 3, GSK, glycogen synthase kinase 3. And it's implicated in apoptosis. So if you inhibit that pathway of GSK3, the cell is not going to destroy itself, right? It's not going to die. So therefore, it can help with preserving, cell that we have there. That's why sometimes they even use lithium for like, they have studies now for lithium with Alzheimer's because it's helping preserve neurons. All right. It also has some antiviral properties too. There was a study before when COVID was happening that patients on lithium were actually less likely to have COVID because it actually increases your white blood cell. It increases your white blood cell count. It causes your bone marrow to actually increase secretion of white blood cells. All right. Sometimes when you have medications like clozapine and their ANC level, the neutrophil count is dropping, sometimes the technique I use is I add lithium low dose to get it back up so that they can stay on the medication. All right. We'll talk about that when we talk about clozapine and schizophrenia. Lithium also helps with desensitizing the 5-HT1A autoreceptor at the Raphe nuclei. So the Raphe nuclei is where a lot of your serotonin is made, is in your brainstem, and that's creating a lot of serotonin in your brain. So by desensitizing the autoreceptor, it's causing your brain to actually increase more serotonin. All right. So it has some serotonergic off properties, not directly by reuptake, but through other properties. It helps with the pathway of neurogenesis. It stops apoptosis. So it does help with patients who are suicidal for whatever reason. Lithium is one of the meds that is shown to reduce suicidality in mood disorder. So if a patient has chronic, so I've seen patients like that, right? I've had patients that have depression and I add a low dose lithium to their Prozac and for whatever reason, their SI goes away. We don't know the mechanism for it, but it just goes away. And once you stop it, it comes back for whatever reason. All right. So lithium has that property, anti-suicidal properties, which has been shown. Any questions for that? The only downside by lithium, it has to be dosed appropriately because it is toxic to your thyroid, right? It can cause hypothyroid, low thyroid. It can also cause issues with your parathyroid hormone. So it can cause elevated calcium, hyperparathyroidism. It can also cause nephrogenic diabetes insipidus, cause you to pee a lot. because it affects the receptors there in your kidneys. So it can cause a lot of side effects. So it has a very narrow therapeutic index, right? And what's the therapeutic index for lithium? What is it? What to what? What's the cutoff?
0.6 to 1.2.
Points.
What is it? 0.6 to 1.2. All right. 1.2 usually if someone's acutely manic, and that would usually be in a hospital because it's narrow therapeutic index. So you don't want to go too high outpatient because you can't monitor the patient. But once they're stable, you usually bring it down. So normally if someone's outpatient and they're acutely manic and the family's on board, I'm able to treat them and not hospitalize them. I've done that a few times, but you have to be experienced to do that. You load them up on lithium, get it to maybe 0.9, 1.0, their mania gets better, they're sleeping a little bit better. Once they're in the maintenance dose, I bring the maintenance dose down from between 0.6 and 0.75 as a maintenance, not when they're acutely manic or not when they're acutely depressed, right? 0.675. And then we keep it at that. Because the thing is, the lower the level, the less risk of side effects, right? Less risk of it going up to above 1 and them having really bad lithium toxicity, which usually looks like tremors, confusion, abnormal gait, all right? Really bad tremors. So you can have tremors in lithium and not have lithium toxicity. Your level's a little high, but it's coarse tremors, very coarse tremors, right? So if I put my hands out like this and my hands are moving like that, how would you describe those tremors? Well, how would you define that? How would you write that in a chart?
Fine tremors?
What tremors?
Fine?
Yes. So I would write it as, that's good, Jared. It is. They're fine, right? But write it as bilateral, both sides, low amplitude, high frequency, all right? Because the neurologist can read that and kind of distinguish the movement. So both hands, bilateral, right? Low amplitude. So this would be high amplitude, right? That would be coarse. Low amplitude, high frequency, right? So patient comes to my office. I had them stick their hands out, and it was bilateral, high frequency, low amplitude tremors. All right, which usually gets better if you either reduce the dose of lithium or you give them atenolol. Atenolol. Why give them atenolol instead of propranolol? What's the difference?
Propranolol blocks beta 1 and beta 2.
That's true, but talk about the brain now. Which one crosses the brain? Which one doesn't cross the brain? Propranolol crosses the brain, crosses the CNS. That's why we use it for anxiety, right? If someone has um, performance anxiety, like they do public speaking, they're going to be going on a plane, and they only want something that's going to last about an hour to an hour and a half that kicks in decently quick. Propranolol 10 milligrams might work, right? Because it crosses the. And that's why we also use propranolol for akathisia. If someone feels restless and from an antipsychotic medication, they can't sit still, you want a medication that crosses the blood-brain barrier, right? The CNS, because you want it to calm them down and relax them. Now, atenolol is only going to cross it's only the periphery. It's not going to cross. So therefore, you only want to treat it at the peripheries, which is the hands. So that's why you could give them propranolol, but it would be like, giving them something that could make them tired, help, cause them to lose focus, right? Fatigue. But you can do the atenolol, it's just going to help with the tremors. All right. So usually I'll do atenolol with that as opposed to propranolol. Does that make sense? Propranolol wouldn't be wrong, but it would give the patient risk of side effects that you don't really want. If you just want to treat the tremors, do atenolol. All right. Lithium, right? Make sure you know that. How to start it, how to manage the side effects, right? So whenever you start lithium, make sure you do a baseline TSH. Make sure you check baseline calcium to make sure they don't have hypercalcemia already. Make sure you check GFR, glomerular filtration rate, to see if the GFR is okay. Normal adults should be above 100, right? If someone has chronic kidney disease, it might be lower than that, but once it goes below 60, you really have to hold the medication or stop it or consult with a nephrologist to see what the plan is. All right. Because you don't want it to accumulate in the kidneys. If it's not being excreted out, it can lead to lithium toxicity. Lithium toxicity over 1.2 can lead to dialysis. It's an emergency. The person has to have, you have to take them to dialysis to get the lithium out. All right. Lithium also very important because you have to consult the patient on diet. So if I'm eating a lot of salty foods, let's say I'm a college student, I don't really have a good job, so I have to load up on ramen noodles. My sodium intake is very high. What's going to happen to my lithium level? Is it going to increase or is it going to decrease? What do you think?
Decrease?
Why? Why is it going to decrease? because lithium is a salt. Your body can't tell the difference, right? So you're gonna pee out some sodium to balance it out because you're gonna have very high, hypertonic solution in your body, right? Too much salt, you're gonna pee it out, and guess what? You're gonna pee some of that lithium out too. So your lithium level is gonna drop. The opposite is gonna happen too. If you don't have enough salt, your body's gonna retain lithium because it needs to keep salt balanced, right? The water and salt have to be at balance. So therefore, you're gonna have a higher risk of lithium toxicity. All right. High salt intake, low sodium level, low lithium level. High sodium intake, low lithium level, right? Inverse. Because your body's going to pee out that sodium, lithium's going to follow it. Low sodium intake, your body's going to retain lithium, and therefore you're going to have higher lithium levels. All right. So make sure you counsel patients with that. Usually, people who are fasting, athletes who are running, and they make sure that when they stay hydrated, they also take electrolytes with them. Not just drink water, they have to take electrolytes with them. All right, sports drink. Is that clear? Any questions about that?
Can you just repeat the mechanism of action with the GSK3, how that works?
Yeah, it's complicated and it's going to confuse you guys if I go through the pathway, but just know that it's a GSK3 inhibitor, inhibits it. It also inhibits inositol phosphatol, IMP. Both of those are involved in the pathway of apoptosis, right? Programmed cell death.
So it's preventing apoptosis.
Prevents apoptosis by inhibiting one of the needed enzymes for it, GSK3, all right, and IMP, inositol phosphatol. And obviously the serotonergic stuff that I talked about. It desensitizes the dorsiraphe, increases serotonin. That's why there's also a warning, even though I ignore it because it's insignificant, but there is a slight warning if you give someone an SSRI with lithium, it's going to say, even on the EMR, it's going to say risk of serotonin syndrome, right? That's because it increases serotonin indirectly. Any questions
If
with
you had
that?
if you had a patient on lithium and they started to show or they expressed that the depression, would you check for like do a thyroid panel?
Yes,
I mean,
I would do a
would that
thyroid
be
panel.
smart?
Correct. Yeah, I would do a TSH. So that could be a good test question, right? Patient's been on long-term lithium, has been stable, all of a sudden develops really bad depression, is still taking lithium. What is the next step? Draw labs. And it would be check a TSH, right? So if someone has hypothyroidism, what's going to happen? Is TSH going to be high or is it going to be low? What?
High.
Very high, right? Because your body's trying to produce thyroid and it's not. So TSH should be high, and if you do a sensitivity test, the T3, T4, it's going to be low. So what do you do? If someone gets hypothyroidism, do you stop the lithium? If it's working, what do you think? What's the answer?
Can you supplement with levothyroxine?
That's very good, right? Your body can't tell the difference between what's synthetic and what's natural. So obviously it's a risk benefits thing. So explain to them that you don't want to stop lithium because if it's been helping you and it's stopped you from being in the hospital, it stopped you from having suicidal ideation, you really have no replacement for it. So what we can do is give you, either T3 or T4, whichever one, triethylthyronine or Synthroid, and of course, they take it and things normalize. All right. Also, if you go too high, so remember I said if someone is acutely manic and their level of lithium is like 1.1, if you keep that on for too long, it can actually cycle them the other way. It can actually make them depressed. So that's why once they're stable, you really want to put it on a maintenance dose. Because if not, lithium low dose is very different from lithium high dose. They're almost like different, they have different mechanisms almost. So if you go too high in anti-mania, you can remember, think of like a seesaw, you can make them very depressed. So don't keep them on the anti-manic dose for too long. Bring it down once they're stable for a couple of weeks or a couple of months and bring it down to a maintenance dose. Right? And lithium should be dosed all at bedtime also. Because if you dose it at bedtime, it tends to be safer for the kidneys. Because if you take it morning and night, remember, it's going to peak and trough twice in a day, right? You take it, it peaks, then it's going to trough twice, morning and nighttime. If you take it all at night, the half-life of lithium is about 21 hours. So you have 3 hours of your kidneys resting. 3 hours doesn't seem like a lot. But trust me, if your kidney's working nonstop, 3 hours is good for it to rest. because then you're also going to lower the risk of developing, nephrogenic diabetes insipidus. In the beginning, it's going to be polyuria, right? They're going to be peeing nonstop, peeing a lot, peeing a lot. So that could develop eventually to nephrogenic diabetes insipidus, right? They're pretty much flooding. If you do a urine osmolality, you're going to see that it's going to be flooded.
I read somewhere that even though they have the polyuria, you give diuretics.
Yes, some diuretics are safe for it, and usually we use amelioride. Amelioride is what we use for that. Doesn't affect lithium level that much. It does a little bit, but not as the other ones, not like the loop diuretics.
But if you're peeing a lot, why would you give a diuretic?
It works on channels called ENaC. They're sodium channels, ENaC channels, and it blocks those receptors and it stops your urine from actually forming from peeing. It works on sodium channels in your kidney. Yeah. Even though it's a diuretic, it's going to make your body not cause that much. Yeah. It's an ENaC inhibitor. Good questions. So dosing all at bedtime, right? Doing a level. I like to use immediate release lithium if the person can tolerate it. Because again, immediate release has a shorter half-life and therefore it spares your kidneys from working hard. If you do ER, it doesn't peak as high, it lasts longer, tends to have less nausea, but it's going to cause more, it might cause more harm to your kidneys because it's an extended release, it's staying long in your system. And the trough time is a little bit less. So your body doesn't get a chance to recover from it. Because remember, bipolar is long game, right? The person is not going to be on these meds for 2 years. They're going to be on this lifelong, most likely. So if you can preserve the kidney functioning now at a young age, they can stay on the lithium much longer than if you just bombed them with ER and a high dose and didn't put it down to maintenance dose. If that makes sense. Another treatment for bipolar is what? Mood stabilizer. Evan, you talked about it. What was that? It works on sodium channels and calcium channels. What was that medication?
Depakote,
Right.
valproic acid.
Valproic acid, right? We don't use it as much anymore. I actually stopped prescribing it. It's been a couple of years since I prescribed it, only because my population, people who want to give birth, I would work a lot with teenagers and a lot of young adults now. So I give them medication that if they wanted to have kids, there's a higher risk of teratogenicity, right? And can impair that. So I don't use it as much. But the good thing about Depakote is that it does work on GABA. It tends to calm people down from mania pretty quickly. You can load the dose. Usually it's 20 to 30 milligrams per kilogram, given, in 3 divided doses in 24 hours, you can load it. They usually do it at inpatient. And it can work quick. That's why you see an inpatient, a lot of people get put on Depakote because it calms them down. Very GABAergic. The downside, it could be hepatotoxic, right? So it makes you check ALT, AST pretty regularly. Make sure that you check for hyperammonemia, check ammonia levels, especially if they're only check ammonia levels if they're confused. If they have like confusion, they don't seem like themselves, a little different than they were when they were manic. Do an ammonia level, right? If ammonia level is too high, they put them on lactulose and it helps them normalize their ammonia levels, right? They poop out the ammonia. It binds the ammonia, the lactulose. Any questions with that? So you have lithium, which is FDA approved for mania, right? And maintenance. You have Depakote, which is FDA approved for mania and maintenance, right? You have, what else do we use? Lamotrigine, which is only FDA approved for maintenance, right? Even though we use it for depression, lamotrigine is also an anticonvulsant that we use that works on, it's NMDA antagonist, right? So it helps with depression and also works on channels also, sodium and calcium channels, and NMDA antagonism. That's why it helps with depression, all right? The thing you need to know about lamotrigine, it has to be started pretty regimented, because if you go too fast, too soon, there's a high risk of what? What is
Rash.
very good? What is it called?
Is it Steven Johnson or not that
Yeah,
severe?
it is Steven Johnson. What's another name for it?
Redmond?
Toxic epidermal necrolysis syndrome, TENS. Toxic epidermal on the skin, necrolysis, because it kills off the skin, syndrome. All right. Usually you'll see it on the face, the mucosa. They'll usually be accompanied by a fever, joint pain, malaise. All right. And once you have the systemic signs, you got to stop it right away and send them to the emergency room. all right? Which is why you have to start it very slowly, 25 milligrams usually for 2 weeks, 50 milligrams for 2 weeks, 100 milligrams for a month, and then 50 milligram increments every month. So you get, maybe therapeutic dose between 150 and maybe 200 milligrams, or maybe 100 or 200 milligrams, all right? Now, if they miss more than 5 days, you have to restart the titration again and make sure you document that. You tell the patient that. So let's say they go on vacation, they go to Aruba for a week, they forget their medication at home. They do not, and they're stable on 150 milligrams, do not go back home and start taking 150 again if you miss more than 5 days. Let me know so I can give you a script and we'll restart the titration again from 25. Because if not, your risk of developing Stevens-Johnson is very high. All right. I think last time I checked, normally it's 1 out of 10,000, which is still pretty high. 1 out of 10,000. All right. 1 out of 10 will develop an acute maculopapular rash, though. Those are the rashes that you see on the skin. That you push on it, it blanches, right? You put some hydrocortisone, it goes away. It usually doesn't involve the mucosa. Right? There's no fever, there's no joint pain accompanied by it. And they'll tell you, I've had this rash before. Once it's like on the trunk, on the neck, on the face, multiple rashes, right? It's a little weird looking. Stop the medication right away.
Did you
A lot of
say
times you stop the rash and it goes away and you can restart. Yes.
did you say valproic acid was approved for mania and maintenance or just mania?
Both.
And can you go back? I missed what you said for the Depakote dosing. You said 20 to 30 milligram per kilogram, multiple
Divided into 3
day.
separate doses in 24 hours.
Okay.
Yeah.
And they could start on that dose right away.
In an emergency situation, you have to load it. But most patients don't do that in the hospital now because they don't want the risk of hepatotoxicity. They'll probably give you the trifecta, right? Which is Depakote, an atypical antipsychotic like olanzapine, and maybe Ativan as an injection to calm you down. So that's probably used more commonly. Okay, atypical antipsychotics. All right, most of them are approved for acute mania. Most of them. But there's only a few of them that are approved for bipolar depression. So those are the ones that I want you to know. Which medications are approved for bipolar depression? There's not many of them. There's only a handful. Name some.
Quetiapine.
Quetiapine is one. Very good. Seroquel. Give me another one.
Cariprazine.
Cariprazine. That's two. Very good.
Risperidone?
I'm sorry?
Risperidone?
No, risperidone is not approved for bipolar depression. No.
Latuda.
Latuda, lurasidone. Very good. There's one more. It's atypical.
Aripiprazole.
No, it's not. Lumateperone, Caplyta, it's a newer medication. All right. Abilify confuses a lot of people because yes, we use it as an adjunct for MDD depression, and people do use it off label for bipolar depression. But when he did the studies, it was actually it was a failed study. It didn't get approval. So even though some providers do use it, I've seen it. So sometimes what happens is people have it on for with an SSRI and Abilify as an adjunct, and it's unclear if it's bipolar depression or MDD with psychotic features or treatment-resistant depression, right? Because there's a lot of overlap there. So therefore, it stays on board. But again, if it was a test question, since I'm teaching you guys, we're trying to go by FDA approval. Abilify is not FDA approved for bipolar depression, right? It's approved for bipolar mania, maintenance, schizophrenia, and adjunct for MDD. All right, is that clear? Not bipolar depression. Only as an adjunct for unipolar depression. Unipolar, not bipolar. Another one that we use sometimes is carbamazepine, Tegretol. All right, that's a mood stabilizer, also anticonvulsant. That's used for mania, bipolar mania. All right. The thing about carbamazepine, Tegretol, is that it induces its own metabolism. Right? It's a very strong inducer of enzymes, but also induces its own metabolism. So that means that over time, you're going to have to make dose adjustment because it's going to increase the amount of enzymes that metabolizes it. So therefore, you're going to have to do. That's why they say usually when you prescribe carbamazepine, you should do a carbamazepine level after 10 days because it takes about 10 days for your body to increase the amount of CYP enzymes for you to get an accurate level. So therefore, when you're increasing it, wait until 10 days to do a level, and then you can check it from there, right? Normal levels between 6 and 12 nanograms per ml for carbamazepine, all right? But remember, it's a pan inducer, so it induces almost all of the enzymes. So all those other medications that are 2D6, 2C9, 2C19, 3A4, they're going to get eaten up also. So you're going to have to actually adjust those meds. So let's say, for instance, someone has bipolar disorder mania, right? That's very hard to control. They're on Abilify for agitation of bipolar mania, but that by itself was not enough. They're on hydroxyzine for sleep. They're on a beta blocker for anxiety, right? All those meds are 2D6, 3A4. You put them on carbamazepine, those meds are going to stop working after 10 days. You're going to have to increase the dose of those medications, right? Increase the propranolol, increase the hydroxyzine, increase the Abilify. But guess what? Then you find out, oh, I don't like the carbamazepine. It's making me too sedated. If you stop the carbamazepine, you have to reduce those meds back to the level that it was before you start the carbamazepine. If not, you're going to get rebound and they're going to have really bad side effects. Does that make sense? Because the carbamazepine is on board, so you're dosing your current regimen based on that carbamazepine, right? Induction. Takes about a week to 10 days for it to build up. Once you reduce the medication, you're going to have to reduce those other meds too, or else you're going to have very high levels of those other medications. All right? Any other questions?
So if you prescribe the carbamazepine for your patient, you would like consult with the primary care to make sure that whatever medications they were on were adjusted, or
You should. That's why I don't put patients on carbamazepine that regularly because it's going to mess up the regimen for all their medications, right? What if someone is on tamoxifen for breast cancer and now you give them carbamazepine? I'm sorry, on a medication that's affected by that, right? Not tamoxifen, because actually they'll get a high level of that. But actually, that might not be good. Tamoxifen level is going to go up, right? Because it's a prodrug. So you're going to have increased metabolism of that medication, a higher ratio of tamoxifen, and they might have side effects from that, right? Or codeine to morphine, right? They're on codeine, they get carbamazepine, they get a higher dose, they're going to be more sedated, right? More confused. So I usually will consult with their other doctors and say, hey, I've tried all the other medications. Carbamazepine is the only option. Is there a way you can switch these medications so that they can coincide with the carbamazepine? Which I think from outpatient is probably not practical. It'll probably be impossible to do it, except if you work for a big hospital system, which all of you guys are rounding on the same patient, right? Like you're a team for psychiatry, there's neurologists, there's cardiologists, and everyone talks about that patient weekly. So you guys can make the adjustments at the same time. That's the only way I think it would work. So I think, practically that will probably never happen. What does happen though is the patient goes to the neurologist and the neurologist doesn't tell you, puts them on carbamazepine for like nerve pain or trigeminal neuralgia, and then it messes up your regimen, right? That's usually what happens most likely. Or migraines. They get put on carbamazepine for migraines. I know it's a heavy subject, but since all my videos from the other semesters are on there and I'm talking about all this stuff, I don't really want to repeat myself because you can watch the videos again. So if you have any other questions, we can talk about it in higher detail.
Oh, for Caplyta, I read that it has agonistic effects on dopamine receptors. How is that possible if it's an antipsychotic?
Great question. So it's it's a partial agonist at the presynaptic neuron. So a neuron, a dopamine neuron, right, which spits out dopamine, has autoreceptors on it, right? Some of those autoreceptors are actually D2 receptors. So technically, if you give someone Haldol, you're going to be blocking the postsynaptic receptor, right? But you're also blocking the autoreceptor on the presynaptic. So in a way, you're actually increasing the amount of dopamine released. So why do you think we need such high doses of Haldol and we need to block about, I don't know, 60 to 80% of dopamine receptors to get an antipsychotic effect, right? With Caplyta, if you look at the package insert in the research, it only needs about 20 to 40% of dopamine blockade to have an antipsychotic effect because it's hitting that autoreceptor, telling that presynaptic neuron, when you hit the autoreceptor, it's a shutoff valve, right? So it's telling that autoreceptor to reduce the amount of dopamine being released by the presynaptic, so therefore you don't have to block as much at the postsynaptic. Does that make sense? You have the presynaptic, which is secreting dopamine, has an autoreceptor, which regulates its release. That autoreceptor, when it gets hit with a partial agonist, it's going to start decreasing the amount of dopamine release. Therefore, you don't have to block that much in the postsynaptic, right? Only 20 to 40%, which is why it has a very low risk of dystonia, Parkinsonism, thyroid dyskinesia, all the side effects that have to do with very high dopamine blockade, all right, or very, very long dopamine blockade. Does that make sense?
Yeah. So does it also block dopamine at the postsynaptic receptor?
Yes, it does.
Okay.
It does. But it doesn't have to block as much of it
Gotcha.
because
Okay.
it's hitting that autoreceptor in the presynaptic neuron. Yeah. It's a very mild D2 blocker, similar to clozapine.
I have another question. It doesn't have to do with the meds per se, but it has to do with upregulation and downregulation.
Okay.
If someone who has schizophrenia has increased dopamine levels, wouldn't their dopamine receptors downregulate?
Okay, you should explain it. In what part of the brain is there too much dopamine, and where would it downregulate?
There's too much dopamine in the mesolimbic pathway.
Yes, your body does downregulate to try to adapt to it, but your body still continues to release dopamine though. But that's an interesting, hypothesis that you have, right? Because remember, schizophrenia is an umbrella term that encompasses many different disorders. Even though we call it schizophrenia, it's probably schizophrenias in reality, right? Why do some people respond to dopamine blockade and some people don't? Why do some people respond to 5-HT2A antagonism for psychosis and some people don't? Why do some people respond to clozapine, which modulates glutamate, and some people don't? Right? Because there could be many different pathways that cause psychosis-like symptoms, and therefore only specific people, but we can't do a genetic testing. I can't do a testing with you, Evan, and say, hey, your form of schizophrenia is due to excess dopamine. Therefore, I give you Haldol or risperidone and you'll get better. I don't really know. So we have to trial you on these meds and kind of make, what do you call it? Hypotheses and what I think is going to help you, right? And go by that and see what happens. So even though it's dopamine driven, the positive symptoms, we don't know what else is happening there. Acetylcholine might be implicated. That's why there's a new class of meds now called M1, M4 agonists, right? I'm not going to say the name, but xanomeline trospium is a generic name. It's a new class of medication that innervates M1, M4 that helps with psychosis, down the pathway. All right. On guys, no questions. It's Valentine's Day. I could be listening to the weekend right now, drinking champagne with my wife.
I have a question about with the upregulation and downregulation, how your body always wants to reach homeostasis.
Mhm.
Like, how do you explain then, like, how do people maintain like a therapeutic level then if it's always trying to find homeostasis?
Therapeutic level of what in particular?
Well, just like drugs in general, like what makes sometimes like you find the right dose and it works if your body's always going to like try
Well,
to
that's
get
the
home.
problem. Your body does try to maintain homeostasis, but there comes a point, like CHF, like congestive heart failure, right? Why does someone have CHF? Because it's the inability of the body to go back to homeostasis, whether it's issues with baroreceptors or issues with, different parts of your body causing CHF, right? Depending if it's left side or right side. But there comes a point in which your body's not able to go back to homeostasis again. That's when illness happens, right? Maybe initially you might have early symptoms of schizophrenia, which is, prodrome, right? And you might have, we call them blips, brief and limited intermittent psychotic symptoms, right? So let's say, for instance, I don't know, if you have a kid and you see them and you might see them staring off out the window, and then They go back and say, hey, what's going on? What's wrong? "Oh, I thought I heard something," right? It's very brief and limited. Your body goes back to homeostasis, and that might not happen again, right? But it keeps
Mhm.
happening again. And there comes a point in which your body can't adapt to that anymore, and it becomes full-blown psychosis or schizophrenia. You know what I mean? So it
Okay.
tries. That's why sometimes chronic alcohol use, right? Why is it that people who have chronic alcohol use, they abstain from alcohol, but they have residual symptoms? Not just the liver issues, but they have something called PAWS, protracted alcohol withdrawal syndrome, which looks like depression or anxiety, but the last thing they used was 10 years ago, right? Your body tried to go back to homeostasis when you stopped the alcohol, but the damage was done already. You couldn't go back to homeostasis, if that makes sense.
Okay.
All right. So there comes a point in which your body can no longer go back to what it was. That's why with schizophrenia, your baseline drops. So maybe if you
Okay.
treat someone early, they can have full remission the first time, right? But then they have 4 or 5 symptoms, and now their baseline is a lot worse, but they're still able to function outside the hospital, but they're still having psychosis, which can be controlled, right? Because the body can
Okay.
no longer adapt to what it was before. Remember, the meds are only treatments. We don't have any cures. So I tell patients, do your best to stay away from drugs, go to therapy, try to eat better if you can, do yoga, the regular stuff. Because the more you do the healthy stuff and less of the unhealthy stuff like drugs and other stuff, the better your body can normalize, and you try your best to get it back to the way it was.
Is what you were just speaking about, because I read something about, I don't know if it was mania, that said the more episodes of mania, the bigger the ventricles of the brain were. Is that is that why it gets kind of more severe over time, is because you're losing part, like areas of your brain?
Yeah, that's one of the. So normally, there's different studies, but I can't think of the person who did the test. Oh man, I always cite it too. You guys like the fourth class that I taught today. I've been teaching since 2 p.m. today. There was a study in which they were doing fMRIs of the brain, and they were showing that first have psychosis within the first 5 years, you lose about 2% of your brain mass. So that equates to about 10% over 5 years. So that's significant. So that might reflect as, enlarged ventricles because your ventricles getting bigger, but that's all dead space, right? That's CSF, but you're losing a lot of your matter. So therefore, you're losing about 10% of your brain matter, right? We can slow it down, but we can't prevent it, unfortunately. So mania and psychosis, similar. They actually share a lot of their genes, mania and psychosis. And schizophrenia. Sorry, not psychosis.
Can you talk about a little of the mechanism of action of mirtazapine? I found that a little confusing.
Mirtazapine. All right. Anyone want to chime in? Anyone know about mirtazapine before I explain it? No. Okay. So think of mirtazapine is going to take you to the moon, right? Mirtazapine take you to the moon. NASA, 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 mirtazapine. All right. NA stands for norepinephrine antagonist. So specifically, norepinephrine 2. All right. Alpha 2 antagonist. So alpha 2 antagonist also is on a serotonin heteroreceptor, which means that there could be a serotonin neuron that has norepinephrine on it, a norepinephrine 2 receptor that's an autoreceptor. So what happens when you block an autoreceptor? You can't shut it off, right? So therefore, it's going to increase serotonin indirectly. All right. It's also a specific serotonin antagonist. So it hits 5-HT2C, 5-HT3, 5-HT2A, 5-HT1A. So 5-HT1A partial agonist, 5-HT2A antagonist, 5-HT3 antagonist, which helps with nausea and appetite. That's why we give it to patients who aren't eating. 5-HTC, which is an a GABA interneuron, which increases serotonin, norepinephrine, and dopamine. All right, so those are the mechanisms. Alpha 2 antagonist on a serotonin neuron, right, as an autoreceptor, and specific serotonin antagonist. Is that enough for you?
More than enough, thank you.
Also antihistamine, anticholinergic. That's why we give it as a sleep medication sometimes. It helps with insomnia at 15 milligrams. You can give it. People can fall asleep with it. So the really significant part is the fact that it's a antihistamine and it also 5-HT2C antagonist. Those two help with sleep and help with appetite. Right? 5-HT2C help with appetite and antihistamine help with appetite.
Is mirtazapine because it does all of those things like trazodone, where it'll work differently at depending on how you dose it? or no?
Uh, from my belief, no, it's not. It's not like trazodone where you increase the dose and it becomes more serotonergic. You go from 50 to 100 to 150. Mirtazapine, I believe 15 is just as potent as an antidepressant as you go to 45. But trazodone, remember, if people are getting trazodone as a hypnotic dose, 50 to 100 is a hypnotic dose. You have to go above that, 150 and higher for it to be an antidepressant, right? It hits serotonin a little bit more when you go higher. It's more serotonergic. So similar to quetiapine, right? So quetiapine, low dose, right? We were talking about the bipolar depression, 50 to 100 milligrams. Insomnia, 100 to 200, maybe adjunct for MDD depression. 300, 400, bipolar depression. 400 higher, bipolar mania, all right, or schizophrenia. What can you give to someone who you start an SSRI, it's working for them, but they're having sexual side effects? Chanel, what about you? I haven't heard from you all night. What do you do? Someone's on Lexapro, it's working, but they're having sexual side effects. They're willing to stay on it, but they want the sexual side effects to go away. What can you add?
Um, I don't know.
No problem. Tanya, what about you? Wanna take a guess? What do you think?
I said, I hope he doesn't call on Tanya. I don't know either.
So a lot of times when you give SSRIs, right, so 5-HT2A, if you guys don't know that already, is a brake for dopamine, right? So if you block the brake, dopamine is going to go up, right? So what happens if you increase serotonin with a SSRI and it hits the 5-HT2A receptor? If I told you blocking it increases dopamine, what's going to happen to dopamine if you innervate it? It's going to go down, right? So technically, you need dopamine for pleasure, for drive, for orgasm, right? For sexual arousal, for motivation. So sometimes patients who have SSRIs, it might help with other things, but too much serotonin will say, hey, I feel flat. I have low libido, I have issues with erection or orgasm. So you want to give them dopamine, right? So one way is giving them Wellbutrin. You can add Wellbutrin. As long as there's no risk factors like seizure, you don't have a history of seizure or anything that would cause a seizure, Wellbutrin on top of that might be a good option, all right? Sometimes what I'll do first is I'll give them maybe PRN Viagra because that'll kick in faster. Because it could take a month or two for Wellbutrin to kick in. So I don't want a person to suffer. So maybe the Viagra in the beginning to help them get their confidence, and then obviously the Wellbutrin should kick in. All right.
I'm sorry, can you just repeat what you said about 5-HT2A being a brake for dopamine?
Yes. 5-HT2A, when you block it, it's on a GABA interneuron, it's gonna increase dopamine, right? That's why antipsychotics, atypicals that have less EPS in the nigrostriatal pathway, because you're blocking it, it causes movement disorders. You give them 5-HT2A antagonists because it'll help increase dopamine in that pathway and it'll help them with their movements, right? But if you increase serotonin too much, say with a serotonin reuptake inhibitor, it's going to hit those receptors and it's going to downregulate dopamine, which can cause issues with motivation. So, instead of giving them you can give them a 5-HT2A antagonist too, right? That's what trazodone does. So you can do it that way by giving them trazodone to help with the sexual side effects, or you can give them Wellbutrin, either way. So you can increase dopamine by doing a reuptake inhibitor like Wellbutrin, a DNRI, or a 5-HT2A antagonist, which will block the receptor so serotonin can bind to it and cause downregulation of dopamine. Does that make sense? Enrique, when would you use trazodone over Wellbutrin for sexual side effects? What do you think?
I'm not sure, not gonna lie.
All right, take a guess. Take a guess. Why would trazodone be a better option than Wellbutrin if someone has what symptom at night?
Uh, Difficulty sleeping?
Very good, insomnia, right? Because trazodone is an antihistamine and also helps with sleep. So why not give them trazodone if they have insomnia also and they're having sexual side effects? If someone's having issues with energy, focus in the daytime, then maybe Wellbutrin would be a good option to add to the SSRI. You understand? If someone has issues with appetite and sleep, maybe Remeron, mirtazapine, right? Because I told you it helps with appetite. It also helps with sleep, would be a good option. Understand? So you really want to add a medication for the patient that fits their clinical profile, right? Don't just pick random medications because it's an algorithm. No. Based on the symptoms, based on the pharmacokinetics, based on the pharmacodynamics of the mechanism of action, you pick specific medications for that patient profile. All right. Low energy, low motivation, seems like a dopamine or epinephrine symptom to me. So I'm going to offer you Wellbutrin. All right. Someone has comorbid anxiety, has maybe some OCD symptoms. Maybe sertraline would be a good option. It's also FDA approved for OCD. Does that make sense? You want to give the least amount of medications that encompasses the most evidence-based diagnoses. All right. PTSD, sertraline would be a good option, or really bad anxiety and they can tolerate it, maybe Paxil. If they have PTSD, that's also FDA approved for PTSD. See what I'm getting at? You don't just you prescribe based on the mechanism of action, not just because it's an SRI or DNRI or whatever. It doesn't matter.
And you said like for testing purposes, it's more like knowing that like what areas, like what you would give, not necessarily the dosages, not to be focused
Yeah,
on that, more
don't worry about those. I'm not gonna ask about doses. I do want
more
to
the
know.
reason why you're doing it,
Correct.
giving it.
Yeah, I'm not gonna say like, is it sertraline 50, sertraline 100? I mean, just know that it's sertraline.
Feel like I'm spending like 90% of my time studying like, okay, this drug is a substrate of this enzyme and it inhibits this
That's
and
important too. That's important too. Yeah, that's important. Yeah. All that's important.
is there any like anything to focus kind of that concept, or is it just like you got to know every single thing it's a substrate of and you got to know every single thing it's an inhibitor of?
You kind of have to. I mean, if you want to be a black belt, yes. I did it. If I can do it, you can do it. It's possible. Trust me. Did you know how long this class used to be? That videos that you saw from the very beginning, the early classes, those were 6-week classes. I taught the same material in 6 weeks. And I didn't cut any corners. Those students were forced to know everything in 6 weeks. Then it moved to 8 weeks. And now it's 16 weeks. So it went from a 6-week course to an 8-week course to now a 16-week course. So you guys are lucky. You have 16 weeks. That's why if you look at the syllabus, I didn't know what to do at the end because since they prolonged it, I was so used to teaching the class in like 6 weeks and teaching this class in 8 weeks that I didn't know what to do with myself at the end. I had to like extend it. But there's a lot of material. I can definitely elaborate. I can do a month just on lithium alone, honestly, and teach you about lithium in 1 month. Just talk about all the details about it, how it works, how to manage it. But the key is knowing a little bit about everything so that you can make, when you see a test exam, you can kind of use your clinical judgment to say, hey, it can't be that, but it might be this. Trust me, I'm not going to ask questions that are very detailed that the nuances are very close. Like I'm not going to say patients having issues with insomnia, would you give them trazodone or mirtazapine? I know they're both good for insomnia, right? So there as a clinician, yes, you might have to know the minute details, but as a student, I'm just going to keep it very basic, right? Sexual side effects, issues with focus and energy. Is it Wellbutrin or trazodone? Obviously, the answer is going to be Wellbutrin. Patient has a history of seizure. Wellbutrin or trazodone? Obviously, the answer is going to be trazodone because Wellbutrin is contraindicated. It lowers seizure threshold. You understand? Someone's a heavy drinker. Obviously, Wellbutrin wouldn't be the answer, right? Because they're going to have a seizure. Someone's morbidly obese. Mirtazapine won't be the answer because why would you want them to eat if if their BMI is already high? You understand? So these are like the questions you have to like know the details. So the beauty of the way I teach is that you get the most out of it when you really put in the hard work, all right? I know this is only our third lecture, but if you expect me to regurgitate the stuff from the book, I'm sorry, you're not going to learn anything. So the point is watching my videos from before so you can fill in the gaps, reading more, and then when you come here, I have no problem explaining it again, but I'm not going to sit here and explain the whole style book to you, all right? It's too much stuff, and we don't really have enough time for it. So you have to come here with a purpose, right? Really, you have to come prepared, right? You're going to get steamrolled. I guarantee you. You're going to get steamrolled at the end if you don't keep up now, right? Because this just gets a lot harder. If you think this is hard, wait till we get to later on and we start doing differentials and we start adding polypharmacy. It's going to get very complex. So you really need to start getting your study now, get your basics down, all right? Because this is actually the easy part. It gets a lot more complex as we get to later on, especially when you start doing substance abuse, right? They're drinking alcohol, they're abusing opioids, and they have schizophrenia. And then I'm asking you about how you're going to manage their medications. It's going to be impossible unless you understand these fundamentals now. And I feel bad for the students that aren't showing up to these lectures. If they think that they're just going to watch this video over and over again, they're not going to get anything out of it. Because you have to ask me the questions that you don't understand, right? You all have different understandings. Some of you guys might absorb SSRIs more than others. Some might understand atypical antipsychotics better, right? So you ask questions, but it should be based on what you don't understand, so I can answer it for you. If someone is a 2C19 poor metabolizer and has MDD, which SSRIs would I not possibly prescribe them because they might have side effects? See what I'm saying? These are the questions you have to know. Lexapro, Celexa, sertraline, right? If I said patient is on Abilify, right, and has depression, which SSRI might not increase the dose of the Abilify? So obviously it's not going to be fluoxetine. It's definitely not going to be paroxetine. So the answer might be sertraline. See, but like you can't answer these questions unless you understand the concepts of what I'm talking about. These are all different concepts you have to understand. What's an inhibitor? What's an inducer? What are the enzymes that affect it? What's the mechanism? Like these are just basic questions. Patient comes to you and is restless, pacing around. They said they were starting a medication. They can't sit still. They have a diagnosis of schizophrenia. What would they possibly prescribe? And I'll probably give you an antidepressant. I'll probably give you a medication, a hypnotic. Then I'll give you an antipsychotic medication like Abilify, right? They're having akathisia from the dopamine. The answer is going to be Abilify. So these are the questions I'm going to ask you. Patient has comorbid depression with ADHD symptoms, doesn't want to take a stimulant, has tried it in the past and couldn't sleep. What might be a good option for them? What would the answer be? Wellbutrin, right? Because bupropion is a DNRI, helps with focus and attention. It's a mild stimulant, and it's also approved for depression. See how I can make like a million questions, but it's going through the same concepts. But if you don't know the concepts, you're not going to be able to answer the questions. Patient has impaired kidney functioning, has bipolar mania. Which medication shouldn't I prescribe them? Lithium, olanzapine, Depakote, Latuda. What medication shouldn't I prescribe them? Impaired kidney functioning.
Lithium.
Very good. Patient is an athlete, but has a co-diagnosis of bipolar disorder, is on lithium, starts having tremors, comes to your office. What should you do first?
Check
Lithium
labs.
level.
Yeah, check lithium level and lower the dose. I would lower the dose first just to be safe, and I would do a level. Hold the dose for 2 days and do a level. patient is lost their job and is on lithium, what should you counsel the patient on? Talked about it. How diet can affect lithium levels, right? They lost their job. They're probably going to be eating a lot of high sodium foods. So counsel them on diet. I hope it makes sense what I'm saying, but this is all just critical thinking of how you guys need to think as practitioners, you know? It's the test is a simulation of, it's not, there might be some questions there too. Patient is having symptoms of dystonia. What dopamine pathway is implicated? So what would the answer for that be? You guys know? Someone has stiff neck. Which dopamine pathway is implicated in dystonia?
Nigrostriatal.
Nigrostriatal pathway. Very good. Patient is having leaking from their breasts. What dopamine pathway is implicated in that? They're on.
Ventricular.
Very good. Tuberoinfundibular, right? Which pathway is implicated in the positive symptom of schizophrenia? Which dopamine pathway?
Mesolimbic.
Very good. Mesolimbic. That's it. There you go. There's not going to be many of those questions. Those questions are probably going to be in the beginning just to establish that you guys have general understanding. Those are give-me's. Those are very just either you know it or you don't. But there's going to be a lot of clinical questions. You have to think about it. You have to know many concepts to answer the questions. All right. Thinking like a provider. Patient comes to you and they have these side effects. What could it possibly be? Right? Serotonin syndrome. You should know what serotonin syndrome is. What is the symptom of serotonin syndrome? I should have read about it. What is it? Taking too many serotonin, what can happen? You can have
Clonus.
right? Hyperreflexia. So you do the reflexes, it's going to be very, very spastic, the movements, right? Clonus, movements of the feet, very strange circular movements. They're going to have their blood pressure, so they're going to have sympathetic response. It's going to be all over the place, right? It might be high 1 second, it might drop the other. They might have confusion, they might have imbalance, right? The key of serotonin syndrome versus NMS, neuroleptic malignant syndrome, which is too much dopamine blockade, is that serotonin, well, common sense, right? Serotonin syndrome, they were on a serotonergic medication. If they were not on a serotonergic medication and they were on antipsychotics, then it would be NMS. They look almost the same. The differential is that the CPK will be very high at NMS because they're going to have lead pipe rigid. They're going to be very rigid and they're going to be flexing the muscles. And when they keep moving and they're shaking, it's going to break down. It can lead to rhabdomyolysis, right? So CPK is going to be elevated. So usually they give them dantrolene to help relax them and calm them down. You treat them symptomatically. Both are treated symptomatically. All right. So know that serotonin syndrome, neuroleptic malignant syndrome, right? Side effect of the medications. Anything? What you want me to clarify anything? Anything? You guys all look confused. Please come prepared for the next class because we're going to review some of this again. It's a lot of material. Like I said, you're going to get steamrolled if you don't keep up.
I have a question.
Yeah.
For the next lecture, the syllabus said it was weeks 5 through 7, but then the test is weeks 1 through 5. Is that right?
Yes. Yes.
So the test is pharmacokinetics, dynamics,
Yep. All the
neuron,
basics.
all that stuff, and then mood disorders.
Yep. Correct. Yeah. Mood disorders a lot. Unipolar depression, MDD with psychotic features, right? Dysthymia, which has been longer than 2 years, right? So there's a lot of different parts of it. Bipolar depression by itself is also a lot. Bipolar disorder, I mean, is a lot. So that's enough. That's very meaty subject already.
But next week's lecture, the 21st, is under anxiety and schizophrenia, I think, like under that section. But that's not on the first test?
No,
Okay.
shouldn't be. Let me see. Sorry. Did you guys, anyone have the syllabus on them? I don't, let me see what they have. Let me look. I have the syllabus open. Let me take a look at it. Sorry.
It's
1 through 5.
anxiety, stress, and psychotic disorders.
Yeah, so what I'm gonna do is, so I'm gonna hold off on that another week because I feel like mood disorders is a long subject and I feel like we're just touching it. And I think you guys came unprepared today, so I want you guys to review that subject, and then we're gonna talk about it again next week. All right? Because I don't want to move ahead because I think this is a big subject and you know you need to really understand it. Because I haven't heard from you in a bit. You don't have any questions? You've been quiet. Aren't you you're a FNP, right? Can you hear
Wait,
me? Aren't you an FNP program?
me? No.
Or no, someone else's. Who's the one that was an FNP program that was on here?
Oh, that was someone from last week.
Oh, sorry. I can my I was gonna say because she was taking this as an elective, so I don't know, maybe she dropped it already. It's not an easy class. This is probably the hardest class you'll ever take in your life, but the most rewarding class. You'll learn the most.
Can you tell me what the function of the sigma 1 receptor is?
So it's interesting. Sigma 1 is really unclear. They say fluoxetine affects that receptor too. It's kind of unclear. So I don't want to speak about it because it's all speculative right now and it hasn't really been well researched. So it's speculative. But what about it? What did you read about it? You tell me.
Uh, Basically something with, it could be an anxiolytic properties.
Yeah, so they're still teasing it out, so it's like unclear. There's a lot of hypothetical receptors out there, and there might be a receptor that we haven't found yet as to why the medications are working. Kind of like clozapine, right? We have some mechanisms of it, but there might be some other mechanisms that we missed. So we're not really sure. Sometimes what they do in these tests is that they do it on rats. They do knockouts. Do you guys know what knockout studies are? Knockout studies are when they breed rats without certain receptors. So for instance, they might breed rats that don't have 5-HT2A receptors and they want to see how they move and how they react. So therefore, you're kind of seeing how someone might react if they don't have the receptor. Like how would someone react if they had 5-HT2A receptors, right? So when they block dopamine receptors in rats, what do you think happens to rats? They don't move, right? They get neurolepsis. They get stiff, like starched. They don't do anything. And then when you give rats dopamine, what happens? They increase in their movement, they increase in goal-directed behavior, they might eat more. How do you think they know if something's addictive? A rat will stop eating just to use that sub. So for instance, if you give a rat a very, very addictive substance, they'll go to that substance and neglect eating because they'll just go to that and they can't stop themselves. That's how you know it's addictive. All right. So they haven't teased it out yet. So it's hypothetical. But good. That's good that you're reading ahead. That's very good. I like that. Be like Evan. He's curious. You guys should all be curious. So be like Evan. That's gonna be a meme.
Can you explain what you meant by that there's a calculator to correct for lithium to correct hypoalbuminemia based on the blood calcium levels?
Oh, I'm sorry. Say that again. How to what?
Um, if you could explain how how you're supposed to correct for the hypoalbuminemia on blood
Oh, you're not,
calcium.
not lithium. That's how you confused. Depakote. You're talking about Depakote. Depakote, not lithium. Depakote is plasma bound. So if you give someone Depakote, right? Depakote is highly protein bound. So if you don't hit a certain level of Depakote, which normally is what 60 to 120, right? Or 130, depending on the lab, or 100, a lot of it's not making it to the brain. So let's say, for instance, someone comes to you and their Depakote level is 50. At 50 nanograms per ml, very little of that is crossing the blood-brain barrier. So very little of that Depakote or valproic acid is going up there. As it goes up, what happens is it saturates your plasma albumin and more Depakote. So technically, if someone had low albumin, you actually don't do a total Depakote level, you do a free Depakote level. So free Depakote is what you're testing. That's actually you're going to see what's making it up to the CNS. Does that make sense? So that's what I mean by correcting it.
Yes, so
Yeah.
for lithium, though, you said that long-term use can cause hypercalcemia and that
Yes, it's hypercalcemia. Yeah, because you mentioned albumin. Yes, it can, because what it does, it messes with two things. It messes with your parathyroid gland receptors to know if calcium is normal or not, right? So what happens is your parathyroid gland is going to keep secreting calcium because it can't tell because those receptors are being blunted by lithium. At the same time, your kidneys, the sensors in your kidneys that tell it to excrete calcium is not working. So your kidneys are retaining calcium and your parathyroid is excreting calcium. So that's going to lead to hypercalcemia, which can lead to anxiety, lead to mood disorders, different things.
and but I think you said that mentioned that functional calcium levels are affected by hypoalbuminemia
Wait, when did I say that?
in the last lecture video.
I'm wondering if you're confusing two subjects. I'm trying to think back. I don't remember. Was I combining? No, because Depakote and lithium so lithium, it doesn't affect albumin, right? Because it's mainly metabolized through the kidneys, it only goes to the kidneys. The Depakote is what's really affected by functioning liver. So you have to make sure you have appropriate albumin, your direct bilirubin needs to be normal, ALT, AST should be okay, PT-NIR should be normal too. There shouldn't be any signs of ascites or anything, any swelling, nothing like that. So I'm trying to understand. So correcting in which, because I wonder if you're mixing both of the concepts.
I guess you said that there was a calculator to correct the.
There is a calculator to correct it. Yeah, it's on the website.
That's for that's for Depakote.
For Depakote, yeah, not lithium. Not lithium, yeah. That's Depakote, not lithium.
So for Depakote, like how does that calculator work?
So I don't want to get too deep in the woods with it because for our purposes here, we can definitely talk about that when we get into the clinical part, when you make it to 51727, only because we're going to get more into medicine and I don't want to confuse the students here that are doing psychopharmacology. But know that if someone is stable on Depakote and they lose their job or they become homeless and they don't have access to food anymore and they start starving themselves and the albumin starts dropping, you're going to have to adjust the Depakote. Because what's going to happen is the albumin drops, there's going to be a lot more free Depakote and they're going to have a higher chance of Depakote toxicity. Understand? So if someone's albumin level is normal and they're doing stable on Depakote, I don't know, 1500, right? Now they don't have access to regular food, they're not eating as much, and then their albumin starts dropping, you're gonna have to correct that. So you probably will have to reduce the Depakote based on what the free Depakote level is when you do that, right? That's how you correct it. Because if not, as the albumin drops, the free Depakote increases and you're gonna put them at risk of, hyperammonemia, Depakote toxicity, right? All those stuff. That's what I want you guys to know for now. Right? Because that's clinically indicated that you'll probably see that more. So just adjust the level based on someone's nutrition status. All right. And for lithium, adjust it based on someone's dietary status. If all of a sudden they say, I want to cut down on my sodium or I want to increase my sodium, you would dose it based on that. All right. But good question. It's good. You're trying to tie everything together, so it's important. It's hard to be effective in psychiatry and not know a little bit of medicine. Now, obviously, I'm not an expert at a lot of stuff, but I know a little bit of medicine that I can actually refer my patients to the right people, right? Where I can tell the difference between ADHD versus an absence seizure. Like, for instance, a mother was telling me that their patient had ADHD, but then when I did the assessment, like, it doesn't seem like ADHD to me. Can you explain it to me? And it was absence seizures. So seizures that are not tonic-clonic. A kid is staring out into space and gets confused and sometimes feels like they don't know who they are. They have they're not A&O times 4 all the time, right? I sent to neurologists and they diagnosed them with absence seizures. So knowing the difference between is it ADHD or is it something medical? Is it hypothyroid, right? Do they have issues with heat intolerance, cold intolerance? Is there changes in their hair, changes in their weight? Are they overeating? Things that might seem like it's endocrine, you need to know how to refer them, or is it depression? So you need to know a little bit about those things too, right? Is it panic attacks, or is it something called POTS, postural orthostatic tachycardia syndrome, right? Where they change. So POTS is a medical issue in which when someone changes position, their body's not able to regulate their blood pressure, right? So for instance, when you change position, when you sit up and you stand up quickly, your body releases norepinephrine, right? Because you want to increase your blood pressure and your pulse to adjust for the fact that your body's going against gravity, right? Gravity's going to push down, and therefore you're not going to perfuse your brain, and you could collapse, right? You get dizzy. POTS impairs that. So people change, and what happens, their body's trying to adapt to it quickly, and they get tachycardic, and their pulse goes up to 160, and they have panic attacks. So if someone says they have uncontrolled panic attacks, I ask them first, have you ever had panic attacks changing position, right? If they say yes, I'm going to send you to your primary care doctor. I want them to rule out POTS, right? Someone is having depression. It's an obese guy, has no neck, right? The typical presentation, and they snore. What do you think I should rule out first? Come on. Snoring,
Yeah.
obstructive sleep apnea.
apnea.
There you go, right? So these are things you need to understand. Now, I'm not going to test about this on the Psychopharm class, but like I said, you're going to get steamrolled as you progress through the program if you don't understand these concepts, because we're going to start mixing in these lookalike things that could be medical, and you have to know how to refer them. So, this is just a peek of what things are escalating to. All right. That's all right. We're going to build it up. As long as you guys show up and you guys do the reading and you really try your best to understand it and let me explain it to you after, you have to get it to repeat, right? So read it, talk about it, verbalize it. So what I usually do is when I was a student, I would read it, then I would read it out loud, and I would try to explain it to myself, and I would write it on a piece of paper and simplify it, right? An hour later, I will try to explain it again. Because remember, the more times that you review something, the more times you're going to build that memory in your hippocampus, right? The remote memory. So once you keep repeating it, then you come to me again, right? On Friday, you ask me that question, I explain it to you again, you write it down again, and therefore you're repeating it. That's how you retain the stuff, all right? So that's how you guys should be learning. Initially by yourself, even if you don't understand it, read it first. Read it out loud if you have to. Take a piece of paper, try to draw it out and simplify it, right? 2 hours later, see if you can still retain that same stuff. All right? Watch my videos on YouTube the night before. Friday, ask me the question and I'll explain it again. And then you'll definitely understand it by then. All right? For all the concepts. That makes sense. All right, look at that. Time flies when you're having fun. So, I hope you guys enjoyed the class. Happy Valentine's Day. Don't have too much fun tonight. And if you have time, watch my videos again. All right? Take care. Any questions? No? All right. See you guys next week.
Thanks, Professor.
Thank you.
Bye.
Bye.